Welcome back to the 49th Annual AAKP National Patient Meeting. I hope you had a good break and are ready for the exciting sessions that lie ahead. I'd like to take this opportunity to introduce the moderator for the next panel, which will be Xenotransplantation Research and Ethics. Richard Knight was going to be with us here today, but he can't make it, so he's doing this remotely live, and we'll see how that goes. Hey, Richard. Richard is the immediate past president of AAKP, kidney transplant recipient. He lives in Maryland, and he's a great friend of the organization and a great friend of mine. Turn it over to Richard.
Thanks, Ed. Hello, everyone, and thank you for joining us at the 49th Annual AAKP National Patient Meeting. Now, I'm supposed to say I'm excited to be back there, and Ed said I couldn't make it, but I don't mind saying it. I checked myself yesterday, as I always do before I go to a patient meeting, and I have COVID. So I wouldn't want to put my fellow patients in any type of danger of catching that. Nevertheless, I'm excited to be back here virtually, and I say hello to everyone else out there in TV land, and thank you for joining us virtually through our event platform today. Again, my name is Richard Knight, former dialysis patient, current kidney transplant, 18 years in October. And as Ed said, I reside in the state of Maryland. And I have the honor of serving as the past president, the immediate past president of AAKP, having turned over the reins to my good friend Ed, who just introduced me. And I think Ed's doing a tremendous job carrying on a legacy of presidents within AAKP. And I must say, semi-retirement is good, but with all that said, I still have the pleasure of representing AAKP on a number of committees, research projects, allied organizations, including NIDDK, National Institute for Health Kidney, National Institutes of Health Kidney Precision Medicine Project, various technical evaluation panels, initiated by the Center for Medicare and Medicaid Services, as well as a board member for the Personalized Medicine Coalition, and I also participate in a Xenotransplant Advisory Committee. So this session is certainly appropriate. As a proud member of AAKP since 2008, I believe that every patient's voice is paramount in determining their care. It's essential that we cultivate an environment that encourages kidney disease research and innovation, driving continuous advancements in care, improved treatments, and solutions for unmet patient needs. And these innovations, as they receive FDA approval, it's equally important that all patients have choice and access. Simply put, we want to make certain that we have the right treatment for the right patient at the right time. This ensures that every patient can live their best life and achieve their life's goals and aspirations. So, to set this session up, it is a well-known fact that innovations in kidney and transplantation must evolve. The status quo is simply unacceptable. It's currently estimated that there are 90,000, I want to repeat that, 90,000 individuals waiting for kidney transplant, but only 25,000 kidney transplants are performed each year, and that's an improvement over previous years. Xenotransplantation, which is transplantation of animal organs into humans, holds incredible potential to help address the critical organ shortages and potentially save countless lives. This topic has been a staple at AAKP events for the past several years. We are proud to bring awareness to this field, and it has been amazing to see how research and science behind this type of transplantation has progressed. And on a personal note, it gives me hope as I approach my 18th year for my transplant, and I certainly hope, or I believe, that it should give everyone out there in a similar situation, I believe that it should give hope to you as well. So with us today, it is my honor to welcome two extraordinary speakers for our session titled Xenotransplantation, Research and Ethics. Because these individuals are two very They're very busy individuals, very busy professionals. They are joining us remotely, but nonetheless, we are thrilled to have their participation, and I know you will learn a lot from both of them. If you turn your attention to the screen, I'm pleased to introduce Dr. Jeffrey Stern. He is assistant professor in the Department of Surgery at NYU Grossman School of Medicine and associate director of the Comprehensive Transplant Center. Dr. Stern is a respected leader in the field of transplantation, dedicated to pushing the boundaries of science and medicine. It's also my privilege to introduce my good friend, Dr. Elisa Gordon. She is a professional. She is a professor in the Department of Surgery and the Center for Biomedical Ethics and Society at Vanderbilt University Medical Center. She is also a medical anthropologist and trained in clinical medical ethics and in community health. Her work focuses on ethical issues in kidney transplantation and donation. Dr. Gordon, she is also a principal investigator for federally funded research to develop, implement, and evaluate culturally targeted, multi-level educational and digital health interventions to reduce health disparities and improve informed consent. Critical areas. Dr. Stern will start us off and help guide us through the research behind this cutting edge field and provide valuable insights into how xenotransplantation may help shape the future of kidney care. Dr. Stern, I turn it over to you.
Thank you so much for that kind introduction. I appreciate it. And I appreciate the opportunity to speak, and I'm sorry for being remote as well. We do have some disclosures, obviously, for our research group, and xenotransplantation in general is largely funded by companies, and so we were obviously funded by some companies for some of our core-based research here. I'll also, not knowing every person in the audience, there is some science in this presentation, and there are also some graphic pictures. So I think we're before lunchtime, so hopefully we're good on that account. Also, I didn't include it on here, but I'm also very optimistic about the future of both kidney transplantation as well as xenotransplantation. So sometimes I speak passionately about both. So I think it's hard to talk about where we're going without talking about where we've been. So I'll run through some of the brief history because I think it frames sort of where we are and what our measures of success are in xenotransplantation and kind of how we got to where we are and how what the current need is, unfortunately, as bad as it is to progress with xenotransplantation. Some of that is based in the history of immunosuppression and kidney transplantation in general. And then we'll go through some of the issues related to the organ shortage. While we were on this technical delay, I was hearing some others mention that as well, but that's sort of one of the biggest impacts that xenotransplantation can have, but also some of the pessimism for the near future of allotransplantation is our organ supply and what may or may not be happening as we get better at caring for humans and or restoring other forms of health without the need for human organ donation. And then I'll end with some thoughts on who may be the best candidates for xenotransplantation and kind of what we may be looking like in the future. So I like to frame transplantation in general into sort of 2 30-year blocks and sort of as technology progresses, adaptation and status quo happen at about that rate. So after steroids and after some of the very early immunosuppressive agents that made transplantation and immunosuppression possible early on, so that we didn't have very early failures of allografts, we made a lot of progress in those first 30 years. Technical parts of the operation, survival, opportunistic infections, all of those things were progressive. In the second 30 years, we made incredible progress. If you look at the 1990s to where we are today, and commonplace renal transplantation, being in the hospital for 3 or 4 days after your living donor kidney transplant, it was really unheard of sort of before the 90s. And now that's our everyday. And that's because of our modern immunosuppression. Those are the same drugs, or we hope to have very similar drugs to these, but tailored to xenotransplantation in the future. And that's why I sort of look at these as 30 years of first progress, 30 years of some amazing progress to get us to where we are today. And hopefully we can look at the next 30 years of how xenotransplantation is incorporated. into clinical practice. So these are our current options right now. Obviously, we have living donation, direct donation from one person to another, or the explosion of paired kidney exchanges across the country, namely the National Kidney Registry, but other registries and other organizations that look at exchanges or altruistic donation. They're really sort of incredible for living donor kidney transplantation. And if we have access to living donors, that's really kind of the gold standard, the best way that we can do kidney transplantation today in general. Deceased donation of kidneys does require the waiting list, and we can wait for single kidneys, we can wait for dual kidneys if the function of each of them is not good enough to do a single kidney transplant alone. We can push the boundaries in deceased donor kidney transplantation. But it's still a limited option, and we're limited by the wait list. So we look at the number of patients on the kidney transplant wait list. Yeah, obviously, I think these are numbers that were just mentioned, but the kidney wait list is very high, and the number of additions each year is also in excess of those that undergo transplantation each year. And this is our total number of donors. So the number of donors recovered across the country is also increasing. These are very optimistic graphs. Organ procurement organizations each year are reaching out to more patients, and more brain dead persons and donors after circulatory determination of death are being recovered each year, and we're getting more organs throughout the supply. I'll go through some other reasons why that is what it is right now and where we're going with that as well. Fortunately, the incidence of end-stage renal disease is also increasing. Some of these numbers are probably artificial when you look back a couple of years for the COVID numbers and the decrease, but everything is really progressive over time. Hypertension, diabetes, all the things that hurt our kidneys keeps getting more and more across the country. That being said, the one thing I didn't mention is that the organ supply is obviously the number one unmet need of where we are right now. I think, as I was mentioning on the other slides, but the number of donors overall is increasing. The number of living donors is staying roughly stagnant. We're keeping that number roughly the same, but we're doing more transplants because of increased deceased donors. And what is the mechanism of death? I've censored out some of the other lower level causes to be pretty clear about our graphs, that patients die and become brain dead because of cardiovascular disease or drug intoxication. The opioid epidemic has dramatically increased our number of donors, young donors without significant other medical problems that become donors of good kidneys for transplantation. Strokes, intracranial hemorrhages stayed roughly the same. And so these are two figures that were updated through 2022, and I hadn't seen any numbers last week when I tried to update them for 2023 yet, but it's U.S. overdose deaths involving opioids. Figure 3 on the left-hand side really starts to show a plateau of U.S. opioid deaths. If you look at heroin, which is the right graph, everything has declined, and over time heroin has become less prevalent in the overall population, and overdose deaths related to heroin have decreased. What we suspect, and we don't have a crystal ball for the future, I hope that, and I'm optimistic that many less people will die or become brain dead and organ donors from opioid overdoses, but it looks like these graphs are starting to level off over the most recent years. Is that because of lots of different things? Probably either supply, increased therapies, increased access to Narcan, other things that are public health emergencies across the country that we're trying to employ to abate this number. It's great, but in transplantation, it means that less people are becoming brain dead through this process. And that means that over time, we may have less donors and less optimal organs for deceased donor transplantation over time. What do we do next? So if the donor pool diminishes over time, do we do less transplants? That's not the right thing for our patients. We have a resource and we have an ability to transplant people, but we need organs. So can we revitalize organs? Can we use organs that we didn't used to use or we thought were not transplantable before? Do we push the bounds of organ recovery, rejuvenation, or other things that we can increase our number of organs as the donor pool diminishes? That's very optimistic, and large fields of research are going into that as well. Can we put lungs on pumps or livers on pumps, hearts on pumps? There are very few actually kidney normothermic pumps. There are a couple that are in the works and are making progress towards FDA approval. But the rehabilitation, the ability to keep a kidney on a pump for more than 24 hours with blood circulation and actually recovering a kidney on a pump doesn't exist yet. All right, so we unfortunately are behind all the other organs on kidneys, and it's because kidneys themselves can be kept on hypothermic pumps or cold pumps for upwards of 24 hours, sometimes 30 hours, sometimes even 45 hours, I think I've transplanted up to. And so the need and the cost ratio for kidneys on normothermic pumps hasn't been there for most recent years. So if we can't do those things, or if we simultaneously do those things, but we still don't have enough organs, what do? We need another organ supply. And that's really where xenotransplantation comes in, or recellularization of old organs as another option. These are just some videos of lungs on a pump, a heart on a pump, and a liver on a pump. And on the bottom here is the LifePort kidney transporter that we've been using for many years, and is a hypothermic pump that just pushes cold preservation fluid through the kidney. We do see improvement in graft function after this kidney pump. Pumping is not new. I think if you click the next button, I think something will pop up in our slide. But Alexis Carrel and Charles Lindbergh started pumping organs in 1935 and trying to recellularize and have environments outside. It took more than 30 years for that advance to come to reality, with predominantly Transmedics doing normothermic pumping right now, but there are some other companies in the space as well. But revitalization of organs and normothermic pumping is certainly very interesting and novel for the future for kidneys as well. So xenotransplantation, as Mr. Knight mentioned, the transfer or transplantation of cells from one organism and species to another. All right, either whole body fluid, cells, tissues, or organs that have had contact with non-human cells, xenotransplantation. This depiction is from 1705 of a blood transfusion from a goat. Obviously, did not work and caused hemolysis, but other sort of options along the way. Our goal is to create or to have an unlimited supply of organs. And will xenotransplantation be right for everyone? We don't know the answer to that, but hopefully we can have really high quality standardized organs ready for as many people as we can. Globally, about 1.5 billion pigs are used for food or other purposes. So we eat pigs. There are lots of things that are very similar about the size of pig organs to human organs. They're not exactly the same, and some pigs grow larger, and different breeds of pigs have different maximal sizes. But there are lots of options, and the general similarity of pigs to humans allows for them to be the optimal source right now. Obviously, the most optimal source would be a closer relative to humans, either non-human primates of some variety that are close to us. The problem is there aren't so many of them. They're hard to breed. They need long life cycles to get to adult human size. And their anatomic similarity and immune system similarity to humans poses significant zoonotic risk. And so there's a moratorium, and we can't use those organs for human transplantations on that after experiences in the 90s. So the predominant epitope, or the predominant thing that causes hyperacute rejection with xenotransplantation, is what's called GAL. And so about 20 years ago, some companies knocked out the GAL epitope from the surface cell. It's a sugar that represents itself on the cell surface of all the cells of pigs. And when you knock it out, these antibodies don't bind. You don't get this massive antibody surge and coagulation of grafts and what's called hyperacute rejection, if people are familiar with that. That was one of the major targets that we knew about, and about 1% of circulating antibodies in most humans are targeted against GAL. GAL is also on bacteria, so you don't have to have been exposed to pigs to have antibodies against GAL. When that was knocked out, the hyperacute rejection went away, and that was actually one of the first xenotransplants that we did up at NYU was transplanting an alpha-gal knockout pig kidney into a brain-dead decedent to make sure that hyperacute rejection did not happen, as it doesn't occur in primates, and that there aren't other immune responses that are adaptive in the early time periods. And those are some of our our early work, and obviously that was an expected result, but something that we really had to prove along the way, and that happened in 2021. Left-hand side here, you see a kidney that's suffering from hyperacute rejection. The blackness of the kidney shows hypoxia and lack of perfusion. The one on the right is that kidney that I was just talking about, a very well-perfused, beautiful-appearing kidney, and I think we're holding the ureter with the pickups there that is about to make some urine after its reperfusion. One of the most promising experiments is something that we did last summer, is we transplanted a xenothymal kidney, so a kidney from a pig that had their thymus auto-implanted. That's an immunologic trick that we're trying to adapt to prevent or to minimize long-term rejection of these kidneys, is to allow someone's native immune system to get educated in the thymus of the pig so that we can be tolerant to pig cells. So there's some very exciting work that we're doing with that portion of the science as we transplant these kidneys along the way. But we were able to maintain this kidney for about 61 days in a brain-dead human. They had donated their body to our experimentation process and was maintained in the ICU. We took out both of the native kidneys of the decedent and transplanted the xeno kidney into there. The kidney made urine right away and was really had beautiful function initially. Early on, as you can see in this graph, the serum creatinine level dropped down to around 0.4, and by the end of the first month, we were looking very good. We did start to see, though, a decline in the creatinine clearance, and we performed a biopsy, and we saw some signs of an antibody-mediated rejection around day 33. We were able to do plasmapheresis and provide conventional immunosuppression adjuncts for an antibody-mediated rejection. We saw improvement of the graft function. And then subsequently, on the postoperative day 49 day biopsy, we saw some signs of a cellular rejection. We provided therapy again, thymoglobulin at that point, and we again saw improvement in the renal function with a creatinine dropping down to 0.2 at the conclusion of the experiment. And really what this shows, and what was remarkable to us, is that we could detect and we could treat xenograft rejection in a decedent. It's unfortunate that we saw it at all. I'm glad that we did, but we were able to say for the first time that the rejection of a xenotransplanted organ that is not hyperacute can respond to conventional therapies and normal immunosuppression that we would give to any human these days. The kidney also responds to, it's not just about urine, it's not just about creatinine, but there are so many functions for our kidneys. So we were able to do a lot of experiments in the decedent model to see how the kidney responded to certain hormones, antidiuretic hormones specifically in this case. Brain-dead donors often suffer from diabetes insipidus. The vasopressin is essential to maintain the homeostasis, and we were able to show increased urine output in response to shutting off the vasopressin level. We were also able to look at other functions of the porcine kidney and whether or not we could maintain calcium and other electrolytes, which all remained quite stable throughout. The explant histology looked like a normal kidney allograft biopsy. On the left is the H&E staining. The glomerulus looks intact. There's very minimal, if any, mesangial expansion. And on the right, the electron microscopy showed intact foot processes. So after 61 days in circulation with the human bloodstream, all functions of the kidney looked fantastic. What do we need to do before human clinical trials? There's a lot of FDA regulations for non-human primate studies, and most recent xenotransplant, we were able to use some of the data from our decedent trial to obtain approval for that. But really, the gold standard has always been non-human primate studies with a year of follow-up, a year of survival. We need to be able to quantify the cross-match, and we need to have subjects who are ready to enroll in phase 1 trials and have them have predicted survivals that are appropriate and comparable to other options. And really, that's how we select and how we're going to need to go from here to figure out who is going to be most eligible for that. Sorry, I'm running slightly over on our time. And obviously, we need to have experienced teams who are able to manage these things in the long run. Who is the ideal candidate? And really, the short answer is we don't yet know the information to that. Who do we think is going to be the best candidate? It's probably those that are likely to not see the immediate benefit of transplantation. Those that are highly sensitized, those that have anticipated long waiting times for organs, whether that's from a geographic region and what the local wait list times look like, or across the United States and the donor supply. If you have a disease process that your predicted time on the waiting list is very long, you may be a good candidate for early xenotransplant trials. As you look at your dialysis access, if you're losing hemodialysis access and you can't do peritoneal dialysis for some reason, those are patients that some form of transplantation we hope would be life-saving, and being in a clinical trial and having other options is really going to be of benefit. The other thing is, what do we define as success? The first heart transplant to a human lasted 18 days. The first pig heart to a human lasted about 8 weeks. We've subsequently done 3 more after those first ones, and we're all unfortunately looking at survivals in the 4 to 8 week range of the xenotransplanted organs. There's obviously a lot more work that we need to do, but we're already above some of the first success stories here. So we need to make progress. We need to make advances through lots of different channels right now to get it to be comparable for our first clinical trials and to sort of have the equipoise to proceed with those. Obviously, several companies are making a lot of investments and steady progress towards human clinical trials, which I'm optimistic. I'm hopeful that in another year or two, we'll be enrolling patients in clinical trials. That would be very exciting, and I'm very optimistic that we could be on that track from this point forward. We've definitely made more progress in the last 4 years in xenotransplantation than in the previous 30, and we need to really undergo that next 30 years of the transplantation journey. I think we're closer than ever. Obviously, all of this work we couldn't do without an incredibly large team over at NYU, and really to the donors that provide, or the families that provide our donors and our whole body donors, decedents for our work, has really been incredible. We thank them tremendously, and the rest of our team. Thank you.
Dr. Stern, thank you for that excellent presentation. And I think we've all been enlightened about the progress. And for me, when you said we've made more progress in the past 4 years than we have in the previous 30, that's home. That's hitting home. So again, thank you for that excellent presentation. Now I'd like to ask everyone to turn their attention back to the screen as Dr. Gordon presents on ethical considerations surrounding xenotransplantation that will be important for kidney transplant patients to understand. Dr. Gordon, my good friend, please take it away.
Wonderful. Thank you so much, Richard, Mr. Knight. It is a real pleasure to be here. I'm sorry I'm not there in person. I would really love to be there, but I really appreciate the opportunity to join you all at this conference today and discuss xenotransplantation and clinical trials. So what I'll be focusing on is the informed consent process and decision-making about first-in-human pig kidney xenotransplant trials. I do want to make some disclosures. You'll see kind of down midway the NCATS funding I received with Drs. Mashke and Guzmano that are supporting this project that I'll be talking about today. My presentation is going to essentially launch from Dr. Stern's presentation previously, and I'm really going to focus on like the next steps. And so again, just by way of background, xenotransplantation refers to the transplant of organs from non-human animals into human recipients. And certainly this is quite promising for potentially alleviating the organ shortage. And as Dr. Stern highlighted, that we are soon to see some first-in-human pig kidney xenotransplant trials taking place. I'm going to actually go a little bit quickly. There's a lot I'd like to cover, so if you want to bear with me, that'd be great. So there's generally speaking in the surveys done in the of the public and patients, there's a lot of acceptance of xenotransplantation as a treatment option. But the concern is that patient attitudes towards participating in a first in human pig trial are relatively unknown. We don't know much about their particular information needs about participating in a xenotransplant clinical trial. Clinical trials present a number of ethical challenges with regard to obtaining informed consent. For example, we just don't have any information about the recipient and the kidney outcomes amongst those who've received or who have received a pig kidney and are participating in a trial specifically. And we don't really know about the risks and the benefits to the trial participants. And, the trial participants may currently have ineffective or non-existent alternative treatment options available to them, which can place people in a quite vulnerable position, making it challenging to make an informed, voluntary decision about participating in a trial. Now, we do know that there have been several FDA expanded access or compassionate use kidney transplant performed. The problem is that they don't provide appropriate comparable outcomes for comparison to clinical trials. We also know that the current federal regulations, the OPTN UNOS policies, do not really address any considerations for obtaining informed consent for xeno trials because all of those regulations and policies are oriented toward human organs. Now, there has been one researcher by Dr. Cooper who developed an informed consent template about what are some of the things that should be disclosed to patients upon considering participation in a trial. The concern here is that that template reflects a provider's perspective and it does not account for a patient's perspectives to address their information needs. For my research project, what we set out to do was understand the first in human pig kidney xenotransplant clinical trials. We wanted to understand what patients' information needs are, what their preferences and what their willingness would be to participate in such a trial. And ultimately, understanding patients' perspectives is so important so that we can design the clinical trial in a way that best meets the patient's needs. Real briefly, we conducted a mixed method study at Northwestern University and Lehigh University, and we also have a 17-member stakeholder committee who provided a lot of feedback throughout this research process. And we included adult English-speaking waitlisted kidney transplant candidates, obtained verbal consent. We conducted semi-structured telephone interviews, online surveys, as well as some usability testing interviews. And we also set out to design a consent form template that was driven by the feedback we received during our interviews. Here you can see we did 28 interviews, 140 people participated in the survey, and 16 people participated in the usability testing interviews. Just focusing here on our interview participants of 28, you can see the demographic breakdown. What I'd like to do is show a little bit of information about how people feel about accepting a pig kidney transplant as part of a trial. And we varied some of the scenario characteristics in terms of how long they've already been waiting and how much more time they have yet to go. And here you can see on the first row, most participants reported being not at all or little or somewhat likely to accept a pig kidney if they've been waiting 1 year and have 5 more to go. The same thing is the case for those who've been waiting 5 years and have one more year to go. And then when it comes down to if someone's been waiting for 5 years and they have 5 more years to go, you'll see that the majority of people switch over to very likely or entirely likely. And what I'd like to highlight here's some quotations from our study participants, and I'm not going to read all of them. I'll just focus on the reasons why people are not at all likely in the first two scenarios. So as one person stated, I've been on the wait list for 2 years, but I feel absolutely great and feel like, my kidney function has not declined in 2 years. So I would not feel like I really need to rush into this. And again, for those who've been on the list for 5 years and have one more year to go, again, the not at all likely, one person stated, if I've already waited for 5 years and I know for sure I only got one more year, then for me, another year can go by in the blink of an eye. So if I've waited for 5, I can wait one more. And now turning to the individuals who have 5 years more to go, those who said entirely or very likely, one person stated, and so the sooner I can get off dialysis, the better you know what I'm saying, shape that my body could be in, because the longer I stay on dialysis, no matter if it's saving my life or not, I know it's causing my body still some damage. So I would be willing to take that chance. Okay, now turning to our online survey, here we have 142 participants, and here are the demographic characteristics. I wanted to highlight a couple of interesting findings here. You'll see we asked people what they thought about the idea of accepting a pig kidney in a trial as part of a bridge. And I would say here we can see over 90% were in favor of that. And then we also asked if they knew that the pig kidney was only going to work for 6 months, would they accept the kidney as part of a trial? The vast majority said no, 85%. And then of those who said yes, there were 12%. I want to call out here, if we turn to the bottom row, the individuals who said that they would accept the kidney if it were to last 1 year, that number increased, the number who said yes, to 30. So it jumped from 12% to 30%. And that's still not the majority, but it's a big jump. So I just wanted to point that out. And now I'd like to turn to some of our results regarding the information needs people reported. And there are about 5 themes that we identified. And so the first theme that came out was that people were really concerned and wanted to be informed about the risk of contracting and transmitting infection. The sub-themes were about the probability of an infection or how curable the infection would be. As one person stated at the top, what potential viruses that can happen? Is there any potential virus that I can give to my family members or to the public? Another theme was about wanting to be informed about the risks and benefits of participating in the trial. For example, they wanted to know about the success rate, the rejection rate, how long the kidney would last. And they also wanted to know what kind of impact the transplant would have on their quality of life. I think these are pretty straightforward. The next theme has to do with the transplant research and the recipient's experience in it. So how many prior transplants have been performed to date? As one person stated, what generation of the trial is this? How far along in the trials are we? How many pig transplants have been done? And so on. And with regard to participants' experiences, what have been the benefits that others have experienced so far? What's happened? Others also wanted to know about the clinical trial logistics, what are the obligations of the participant? What's the schedule? Where do they need to be? What has to get done? Others wanted to know information about the backup plan or an exit strategy. What happens if the kidney failed, and would I be moved to the top of the list for an allotransplant? And lastly, people wanted to know about the pig and its kidney, and this is quite novel. The pig and the kidney's health, the medical condition, the nature of the genetic modification, how the pig was treated, how it was killed, its diet. They also wanted to know the pig's name and its age. And now turning to our usability testing. So, based on all of the results that I've just presented, we developed an informed consent template and we populated it with all the information that people expressed desire learning about. And so then we showed this consent form template to 16 other kidney transplant candidates to see what they thought about it. They overall found that the template was clear and easy to understand, and then they recommended some additional things to be added. For example, clarifying insurance coverage of the research. What happens if, what are the risks if a patient does decide to leave the study, for example. I do want to highlight an interesting finding that although it was not significant, our study participants reported that their preparedness to make a decision about participating in a trial increased after reviewing our consent form template. So beforehand, we asked the question, and about 12.5% felt very or completely prepared. And then afterwards, that more than doubled to 31%. Maybe it's a small sample, and so that's why we didn't see significance, but nonetheless, we saw a movement in the right direction. So I'd like to wrap up here and make a couple concluding remarks. We observed mixed willingness to participate in a first-in-human pig kidney trial, similar to other research. There's a lot of people just wanted a lot more information. And our interview participants reported an increased willingness to participate in a trial if their hypothetical time spent on dialysis would extend from 1 year to 5 years. And, some of the concerns illustrated how time on the waiting list and how individuals' health status shaped patients' thought processes about this. And our findings also suggest that kidney transplant candidates desire a lot of information, extensive information about usual clinical trial research related factors, as well as quite novel factors pertaining to the pig and the xenotransplant research context. We saw movement in the right direction about feeling more prepared to make a decision about participating in a trial after candidates reviewed the consent form. Our goal was not to increase participation, but to ensure that people were informed and feeling prepared to decide either way. And, to conclude here, that the informed consent process should address patients' information needs to facilitate their patient-centered informed decision-making about participating in a pig kidney clinical trial. And future research must assess patients' actual information needs and the adequacy of their comprehension and decision-making upon actual trial initiation. I'd like to acknowledge my research team. Everyone has been vital to the success of our project. I'd like to acknowledge also our advisory committee members. And I also want to acknowledge all of the patients who participated in our different research data collection activities, because without them, we wouldn't know what's important to people. And so we need to know that, again, so that we can design our clinical trials as well as treatment options downstream from there in a way that best suits people's needs. And I wanted to thank you all for listening.
Well, thank you, Dr. Gordon. As always, you provide us with an excellent presentation and great insights. I really enjoyed the way that you are looking to put forth the perspective of a patient, sometimes in a manner that as patients we are not even aware of, but by the way you frame the questions, it helps brings things out. I'm going to turn it over to my good friend Ed Hickey, and if we have time for questions, we will certainly go ahead and do that. But if we're short on time, then we'll break and go for lunch. But again, Dr. Stern and Dr. Gordon, I personally want to thank both of you on behalf of AAKP. You have truly enlightened us, and This video will be very active for quite a while because it's very insightful. So, Ed,
It's
I'm going to
fascinating.
pass it over to you.
Thank you,
We'll
Richard.
go from there.
So we have exactly 25 seconds, so I don't think I could get a question in that amount of time. But thank you both. This is a very exciting area. We had Dr. Montgomery present to us about a year ago with our group, and he was one of the first people to do these transplants. And it's just been fascinating watching the development, and we thank you for your efforts and your interests in making the lives of kidney patients better. So thank you very much for your time.